Donc, bonjour tout le monde. Avant de commencer, veuillez noter que la présentation d'aujourd'hui se déroulera en anglais, puisque notre conférencier est international. Donc, je vous remercie pour votre compréhension. Please note that today's presentation will be held in English. So, can I start? Welcome to our international conference on the cost efficiency specialist in patient rehabilitation, part of the Access workshop series. It's a pleasure to introduce today's speaker, Dr. Berkay Karahacioğlu, medical doctor and member of the Royal College of Physicians. He's currently a specialty registrar in rehabilitation medicine in London, working at the National Hospital for Neurology and Neurosurgery, and an active member of the UK Rehabilitation Outcomes Collaborative, the UKROC. Dr. Karahacioğlu brings a rich background in internal medicine and neurology. His research focuses on the economic impact of specialist rehabilitation, particularly in neurorehabilitation and spinal cord injury care. He uses validated cost evaluation tools to assess how rehabilitation can lead to better outcomes and significant cost saving in healthcare systems. In today's presentation, Dr. Karahacioğlu will share findings from his recent study on trauma patients, demonstrating how the cost of rehabilitation can be offset within months, especially in cases involving traumatic brain and spinal cord injuries. A quick reminder, this session is being recorded and will be shared across CRIR's communication platforms. If you don't prefer to appear in the recording, please switch off your cameras. So, without further ado, I will hand it over to Dr. Karahacioğlu. You can start your conference.
Okay. Thank you very much, Mohammed. So I'm basically in London now. It's 6 o'clock. 5 o'clock. So we've just finished working, and basically we are always collecting this UKROC data. I'm going to tell you more about it, and we are trying to show the commissioners, so people with big pockets, whatever we are doing, which is very expensive. We are doing a complex rehabilitation, specialist rehabilitation, and we need to show that it's actually very cost effective. In the long run, we are actually saving them money. So we were just collecting data, and I came here to do this presentation. So I'm going to present you the data that we have collected last year, and I presented actually in Canada in World Federation of Neurorehabilitation Congress. So just that this is the declaration of interest. Basically, I don't have any conflict of interest on this projects that we have run. And let me tell you a little bit about UKROC. Basically, this is a data that we follow in every level, okay, on admission, during admission, and after admission. So we collect on data on rehabilitation needs. What are the inputs that we have provided during the inpatient stay? Let's imagine a patient. The patient had a spinal cord injury or neuro injury, and they started to have input from speech and language therapists, us doctors. They started to see physiotherapy. Obviously, they have nursing needs. So they had all this input, and obviously it will have a cost. So we put that cost in our data, but we also put what are the functional outcomes that we had. So obviously we use FIM, and we also use PAM as well. I'll further talk about this if you're not familiar. And we are trying to see how effective our treatment was, our rehabilitation was, and how independent we let our patients become, and at the end, how much cost saving we did. And obviously now everything is computerized, so we don't actually calculate these things, the computer calculates it. So the important thing about this data is collected on time. We collect it regularly, and obviously it's audited. So this is FIM efficiency. So imagine as rehab physicians, we don't want to see this patient along here, and we don't want to see the patient along here. We want to see where they get the best rehabilitation recovery rehabilitation outcome. So obviously here we have the length of stay, and here the FIM gain, and we can calculate the efficiency of our rehabilitation, but it doesn't really affect it doesn't really show the cost. And when we bring the patient on C or B level, we have obviously the ceiling effect, and we have obviously the bottom effect. I will be talking about a lot of like different terms. You may not be familiar with it. I wasn't familiar with it when I was working back in Turkey. These are a bit local. For example, for complexity of needs for rehabilitation, how much actually specialty they need. We use something called rehabilitation complexity scale. Actually, it's been translated to French as well, so you may find it. For inputs that we give, we put Northwick Park, nursing dependency in nursing, Northwick Park, healthcare, and Northwick Park therapy inputs. And for outcomes, we put PIMFAM. And episode cost, we use complexity weighted bed day cost. And for cost efficiency, we try to see how much time it's going to take to offset the cost of rehabilitation by saving in the ongoing care needs. I'll show you an animation about it. And obviously, when we say NPDS, the Northwick Park Dependency Scale, how many carriers that the patient needs actually? Because imagine a patient with severe neurodisability because of a traumatic brain injury may need 24-hour care with sometimes double-handed care. Their cost is going to be different. Or someone who had, let's say, Guillain-Barré syndrome, who has mentally okay, doesn't have depression, doesn't have significant needs. He has relatively good voice, so he doesn't need any speech and language therapist, will have relatively less cost. And our cost efficiency model, if you had seen the previous studies, if you haven't, don't worry, I'll send a follow-up email and send all these documents to you. It's been proved to be working in almost every category. Let it be traumatic brain injury, let it be spinal cord injury, peripheral nerve injury, everywhere. But there was this question whether maybe it's just only working for certain type of people. For example, you may argue that for someone who is very severely disabled, who may not have significantly good outcomes, may not really benefit from this specialist rehabilitation, and maybe we are not gonna save much cost in the care needs. But we proved that in this study, that's not the case actually. So we divide them into how dependent they are, how much need they need to have to get the rehabilitation in terms of their care, and we show that they are still very much cost effective. And just the ballpark number, so following traumatic brain injury, if they have specialist neurorehabilitation, not a regular rehabilitation that you could get in maybe an acute hospital, in a specialist neurorehabilitation, we have estimated lifetime saving goal more than £1 million. Okay, so this is the animation that I would like to show you. Imagine a patient, okay, unfortunately had a road traffic accident, not doing very well. So on admission, there is two timelines. One country, let's say one region, were able to put them on a rehabilitation bed, and the other couldn't do that, okay? Because in most countries now, the acute hospitals are readily available, hopefully. But when it comes to rehabilitation, people may not understand the need for it because it is not obvious, isn't it? For example, all my family are doctors, they are surgeons, they are oncologists. But when I tell them what I do, they don't clearly understand the need for it. Because to a naked eye, to untrained eye, even though they are doctors, okay, this guy had a stroke, this gentleman had a stroke, brain injury, whatever. They weren't able to move their right side. And after 4 months admission, they are still not able to move their right side. So what is the point? But actually there's a lot of point because they are actually, on a closer look, they are much more independent. So let's say we invested, okay, in 4 months. A lot of people come and review, put their input. As I said, we work with like 60 specialists here. We have speech and language therapists, physiotherapists, occupational therapists, us doctors. In 4 months, admission costs £65,000. This is a significant amount, and probably it's an underpark. Probably it's much more than that. Probably it's around 100K. But at the end of the day, the country or the region or the patient who hasn't had any rehabilitation, and obviously we come to the private care as well. With this, if they were able to invest in that, they will be saving considerable amount of money in the following care, because they are more independent. They're not going to need 2 carers. They will only need 1 carer. They're going to save £1,250 a week, which is going to mean £65,000 a year. And we're going to say, okay, the time offset, the cost of the specialist rehabilitation was only 12 months. So if they were able to live more than 12 months, it's going to be a lifetime savings, okay? And you can calculate with the tools that we have how much they are expected to live. For example, a tracheostomy patient, a patient with severe traumatic brain injury, with spinal cord injury, you can, there are studies done, and let's say 20 years, okay? In the 20 years, approximately, you're gonna save £1.3 million. Okay, what did we looked in this study? We have a prospectively collected data, but we looked at it retrospectively in 11-year period, and we'll just look at the major trauma, okay? In different level of dependency. As I said, some people might think, okay, maybe the very highly dependent people doesn't really benefit from the rehab, and perhaps with the amount of money that we put in, we may not be saved a significant amount. Or some people might think, okay, they are so severely disabled, they may not even live long enough to offset the cost. So we have, obviously we have a huge data. At the end of the day, I'm not going to go into that, how we did it, but we have 8,700 people that we had to look at. We had to leave a few people like disorder of consciousness, prolonged disorder of consciousness. So you may know this like in an old-term vegetative state. We have calculated this in a different study. So we had to put them aside for this study. And the mean age was 53. Males, obviously, when it comes to trauma, they are always more prone to trauma. Most of them had brain injury, almost 3/4 of them had a brain injury. And we were able to mostly discharge them home, but obviously some of them were very severe. They need to go to nursing home or continued rehabilitation. We have something called slow stream rehab. Sometimes we need to send them back to there, and some of them had to go to acute hospital for problems. How much money we spent? We spent approximately on mean terms £45,000, and length of the stay was approximately 2.5 months. And annual saving cost was £83,000. So that means that in around 6 months' time, after they are discharged, actually the government saved the money, because whatever they put in NHS, whatever they put in the hospital, they take it back in the care cost. Okay, so I don't know if you are familiar with this Northwick Park dependency scale, but it's a very smart scale. I only learned this when I come to London. So basically we divide them into 3 categories, okay? Very grossly. The low category means that they don't need much intervention, they don't need much care. A little bit of observation is fine. For example, you can think of someone with a peripheral nerve injury who is well with himself. He has like safety awareness. You don't need to do much, but you need to probably observe. So this is NPDS less than 10. So it's a low dependently. And the medium is in between. Probably they need 1 healthcare assistant or nurse to be with him in most tasks. Let it be like eating food, brushing teeth, etc. And high dependency group, Those people usually are severely injured. It could be high spinal cord injury, significant brain injury. They need probably 2 people at all times to do most of the tasks for him. Obviously, these people have much higher cost of care in the hospital. Okay, and then we look at a few things like how much actually they stayed in the hospital, how much we spent. Obviously, when it comes to the episode cost that I would like to focus on, the low dependency group is less than half of what the high dependency group spent. But actually, when it comes to saving, since they are needing less care after this specialist unit, we are saving actually more than 3 times of those categories. And after maybe 7 months, they're gonna offset the care costs. So in all dependency group, let it be low or high, we are offset the care cost in less than a year. And obviously, when we look at the FIMPAM scores, which is our main outcome tool, I don't know if you are familiar with it, and I'm sure that there are some people haven't seen this before. This is a very smart way to look at the input that we have given and what was the outcome. So the yellow bit that you see is on admission, okay? And the closer it is to the center, more dependent they are, okay? The 7, they are independent, they are eating, for example, like a normal person, independently. 1 or 0 means that they are severely dependent, they need someone to basically help them. And the blue area you see is in the discharge. So this is the FIMPAM split that we do for each and every patient. And obviously, when they are highly dependent, there are so much to gain. And where little dependent, they are mostly already 7 in most areas. There are a few bits that we need to work on, and the gain obviously is less. How is our speed so far? Is there any term that you haven't really understood? You want me to go back and explain? We can wait and check as well. Hi, Claudine. So please, you are free to interrupt me. Okay. And we also obviously need to, when we are doing something medical, we need to look at the injury type as well. We look at it, most of them had brain injury, considerable amount of them have spinal cord injury, but also amputation was significant too. Okay, and then we look at is there any category actually benefits the most from this rehab? And when we look at it, amputation seems to be the most effective. When you are giving a few weeks of admission, spend less than £15,000 in that episode, you gain much more. You are saving probably close to £70,000, and in 2 months, 2.5 months, you are getting whatever you gave, you get it back. And when it comes to TBI, as we say, TBI is the most complex when it comes to rehab, but they have the most to gain, and we are gaining almost 100K a year, and in 7 months we are offsetting the care costs. So to a commissioner, okay, watching this, we can obviously show them, okay, we are spending a lot of money, okay? Imagine a patient comes to a unit and it's £50,000 is just gone like that in a few months, okay? This is, in NHS terms, it is probably 5-10 times more expensive than any surgery, okay? But the gain that we get is incredible. And again, in different FIMPAM scores, again, in traumatic brain surgery, traumatic brain injury, we have a lot of gain. However, when it comes to amputation or other peripheral nerve injury, there is less to gain, but still it is effective. Okay, this was an obviously observational study, but this is our real life clinical practice, and we use it practically to show the commissioners how much work we've done and actually how important for them to create more specialist services. Because imagine, UK is a huge population. We have good amount of specialist neurorehabilitation centers and rehabilitation centers, but you should see our waiting lists. Still, we are not at the same level. So I don't know if you remember the first slide that I showed you, you know, the FIMFAM gains. We're probably missing the critical period, even though people spent in the acute hospital, which they get their acute treatment, they become stable. We don't have enough bed to bring them immediately to the rehab unit where they can actually spend the golden period, the first 6 months. We have to make them wait in an acute hospital, acute bed, unfortunately not receiving the rehabilitation that they need to have. But we can show them saying that if you open this unit, you're going to save this amount of money in the long run. Unfortunately, this QR code doesn't work, but no worries. I'm going to send them to you in a PDF format. So these are the things that I wanted to tell you initially, but there are a few more things that I might add as the question comes along, okay? Is that okay, Mohammed?
Yes.
Okay, 25 minutes. I am a bit over time, but we will have still enough time to questions.
So thank you very much, Dr. Karahacioğlu, for this insightful presentation. Truly appreciate you sharing your expertise with us today. And yes, we will now move on to the Q&A session. So please don't hesitate to raise your hand or type your question in the chat. So I see Dalia Kairi, she have a question.
Hi, thank you, Mohammed. Thank you very much for the presentation. That was really, really interesting. And I guess my main first question is, how difficult was it to put in place what you needed to put in place in order to collect the data that you needed to be able to have this information?
Very good question. So basically what we do, usually the registrars or consultants, so registrars are, you can think them of as like resident doctors about to finish their training and become a consultant. So they fill these documents, which are medical, the medical bits. It takes me probably less than 10 minutes to fill for all patients. And obviously the nurses do their bit and the therapist does their bit. And at the end, the total amount of time that we spent, 3 of us, 30 minutes at top. And obviously you need a dedicated time for that, but for all those patients, and we have in our unit 20 patients, complex patients, and it takes 30 minutes for all. It's not much. And we do it every week, once a week.
And was that set up specifically for this, or it was already in place?
So to be fair, probably Professor Turner-Stokes could explain this much better because this has been in place for the last 10 years. I understand it came as a research project, okay? And then it was shown so effective, every rehab unit started to put in place and it became basically data entry, data registry. So everybody has to do that. And obviously it is very important. Whenever the commissioner asks, you are able to show your work.
Thank you.
Thank you.
Thank you very much.
Philippe Archambault.
Hi, very interesting talks. I missed the first couple of minutes, I'm sorry. But I was wondering if you're in your measures of economic, gains after rehab, does that consider the potential loss in productivity for the caregivers? Because a lot of times caregivers, when they have to care for someone who has a disability, they may reduce their number of hours or choose a lowering paying job or to be more flexible, or they may quit working altogether. So is that taken into account by either directly or indirectly, do you think?
You know, this is an amazing question. Let me share you one thing. Am I allowed to share, Mohammed?
Yeah, we see.
Can you see it?
Yeah. We see the Northwick Park Dependency
Okay.
Score. Yeah.
Okay, you see the table here as well, isn't it? So,
Yes.
so here you can see, okay, this is very, very small actually. Okay. So, for example, washing and dressing, okay? Bathing, showering, it takes half an hour to carer's time. Dressing,
Mhm.
half an hour carer's time. Self-care task, another half an hour. Safety awareness, so the things that you need to do into place, okay?
Mhm.
15 minutes, okay? This could be bringing the, for example, voice recognition, bringing the whatever they need to communicate, okay? The
Mhm.
medication. So all these things are timed. And what happens in the UK? So we have a package of care, okay? In the package of care, we can say that, okay, you need in the morning 2 hours, okay? That means that the care is going to come and we'll have like 15 pounds an hour, 20 pounds an hour. Probably in Canada, it's going to be much higher than the UK. And they're going to do these tasks, get their 20 pounds an hour, 30 pounds an hour, and probably they're going to come, this is the morning, and the mid-morning, they're going to come again, etc., etc. And we're going to calculate how much amount of care they need. And
Yep.
since this is a professional care, we have carers basically funded by the commissioners. This is usually, I mean, this is a huge different thing, but at the end of the day, state pays for it. Okay. If you are very rich, you may need to pay for it yourself. Okay. But at the end of the day, state is going to have some contribution to it. And if you can decrease these numbers, okay, for example, you give them more safety awareness, you put them in a way that they are able to dress themselves, you're going to decrease the care cost. But you are absolutely right. Or how are we going to calculate the person who stopped working to take care of their son, their loved ones, etc.? So this is
Yes.
what happens actually in Turkey. Okay, in Turkey, if your loved one gets dependent, you're going to stop
Mhm.
working and you're going to start taking care of your mother.
Exactly.
So there are previous studies who looked at this, and actually it shows that professional carers are much better psychologically for the carer. It is actually much more cost effective. You doing your own thing, whatever your profession is, and letting the carers work for that specific task is much better because they know how to shower someone, they know how to dress someone. And at the end of the day, even if you are able-bodied and you are trying to help your loved one, psychologically it might be better, but you are still doing a job. You are out of the job market and you are doing something 15 pounds an hour, 20 pounds an hour. Okay, it's still a cost. So you can still approximate. But there is no study that I know how come the carer stopped working and actually it was lost to the overall economy, to the GDP, isn't it? I don't know any study calculated that.
Yeah. Thank you.
Thank
Because
you very much.
it is a reality, I mean, so for
It's
sure.
a reality. I
Even
don't know how
when home care is available, sometimes it's just not enough yeah.
I don't know how it's Canada, but I can tell you this. So imagine, again, specialist neuro rehab. We have a lot of education nurses. Okay, so education nurses not only educate the person who had injured, they only have group sessions and they educate the family as well.
Mhm.
Okay, so I believe calculating this might be much more difficult, but there is a benefit to carer too. I mean, the informal carer, informal next of kin.
Mhm. Okay, well, thank you. Thanks a lot.
Thank you very much, Dr. Karahacioğlu. So Claudine Auger, if you have a question.
So Berkay, thank you so much, and sorry for being late. We were, caught in a meeting, Philippe and I. So Philippe is co-scientific director with me of CRIR. So I just want to make sure that you just talked with Philippe, my co-director with whom we work. And this presentation, I saw your presentation in the past, so I know that I missed the beginning, but The reason why I thought it was interesting for us at CRIR to have you is that we don't collect data as you are doing in the UK in such a systematic way. And probably in the UK, you are the leaders at this level. I don't know to which extent everywhere in UK they're doing such a, I'd say a process that is followed so strictly. But I saw there were some missing data in one of the slides. So what is the level of missing data that you have, even if you say you're doing it every week? I saw it was and the challenges around this, maintaining this approach where you take these measures systematically, and what are the incentives? You seem to say we all do it, and I'm just wondering, what are these incentives around the teams to continue collecting this data so systematically?
Yeah, very good question. So probably when you have the meeting with Professor Turner-Stoke, she's going to be explaining much in detail. But from our point of view, when we have a meeting with NHS England, the people actually who gives us money, okay, we will be able to show them, okay, you are giving us this amount of money. We understand that this is very expensive service we provide. But actually, when you look on a broader sense, you will be actually saving money because NHS England, okay, it seems like a different service, isn't it? It's a healthcare service. But actually, when you look on a broader sense, the government will be paying for the care as well for the patients. Okay. We show them, okay, you give us now, but you're going to save this money later. And from our point of view, for doctors, letting them to feel this is very easy. Okay. We say we need to be auditing these things. It needs to be strict. We cannot miss any data. We have a timetable in our timetable. I have a specific slot that I can just look at this UKROC. And also from our point of view, we bill FinFam and other dependency scores as well. So on our monthly meetings, we will be able to see retrospectively what we have done this month, okay? Not just the cost effectiveness, but since we collect some medical data as well, we will be able to see, okay, we have this many patients with PDOC, prolonged disorder of consciousness. We had this many patients of peripheral nerve injury. From nurses' point of view, they will be able to manage their workload, okay? We have this amount of people who are strictly very dependent, so we will need this many amount of extra nurses to come and help us. So they will be, we say locum, extra agency work. So they will be able to put extra agency work, much on a robust sense. These are like extra benefits of collecting data.
I see. So you create value even for those who enter the data because they actually use it, within a week of entering this information. It is useful.
Exactly.
Okay, directly to the unit.
Claudine, when you look at the data, I mean, you can do color coded and you can see, okay, guys, we have half of the world is highly dependent, okay? This cannot be go like this, okay? Let's manage our admissions, manage our like whatever workload is, or if we need more people to come and help us, we need to manage that. So it's very, very useful. But to be fair, initially, possibly this must have been really, really difficult for professor to put this in place. But at the end we get money from this. So I mean, it is important for us to feel correctly.
Yes, you're talking about auditing. Can you explain what is this process of auditing?
Auditing. So obviously, you know the levels of the rehab, right? We have specialist rehab, level 1, level 2, level 3. And level 1 is the most complex one. So we should be hitting a certain complexity in our patients. If we don't do that, why are we level 1? Okay. So we should be getting the most complex patient. So it will help us to review that as well.
Okay. because each setting has a certain level of care. And this is, I don't think we have this hierarchy here in Quebec. So maybe some of those who are attending your presentation could confirm that. But I remember this very complex level of care when maybe if you can describe their level of need.
course, yeah.
So that we understand maybe these cases, we don't see them in our rehab hospital. So maybe it would be helpful for us. And I see Perrine raised her hand, but maybe if you can give us an idea of who comes on those units with the complex.
Of course, of course. So basically, we have different scoring systems. Don't worry about it. I'll give you an example. Imagine a patient who needs speech and language therapist, okay, because they have tracheostomy. They have psychological needs, okay, they having like post-traumatic stress syndrome. They have medical needs. They have complex like medical issues going on. Let's say their discharge planning is going to be difficult. They will have a lot of spasticity problems. They will need physiotherapy input, occupational therapist input. A lot of specialists needs to put a lot of effort to it, okay? This patient is going to be going to level 1 unit, okay? Because level 1 unit are those units who have all these specialists and in higher numbers, in more specialized number. And the level 2 unit is going to be, they may have all these individually, okay? They may have speech and language therapists, they may have physiotherapists, but the numbers are not going to be high enough. And therefore we say, okay, this patient doesn't need a complex speech and language therapy. They don't need complex nursing needs. They don't need psychology needs, but they have still significant spasticity. They have occupational OT needs, occupational therapy needs. They have complex discharge plan. Okay, let's put this to level 2. And level 3 is going to be the community rehabs, where actually doesn't need much medical input. There are few goals that they need to work on. So we have this leveling system. For example, in our trainings, we usually do in level 1 units, very complex patients, and a few of them are level 2 units. Obviously, this system doesn't work perfectly because what happens is, for example, Claudine, you are a level 2 unit consultant. They made it referral to you, and you see the patient is very complex. It may put a lot of strain to your team, but a few other level 1 units already refused to take because they didn't have any beds. They have significant complex load anyway. At the end, you may end up with this patient, okay, which has very complex needs to go to level 1. So everything's in between is also permeable.
I see. So you use also the system to verify, this is what you call auditing, that you have the right level. So it's used for different purposes. Okay, thank you.
No worries.
Thank you, Dr. Karahacioğlu. Perrine, Faresh, have a question.
Yeah, thank you so much. This is fascinating, isn't it? It's really something we don't do much in Quebec. Probably we should do that more. I have one more question now. When you were talking about the level 1 and level 2, I do believe that it's still inpatient rehab, isn't it?
Yes.
So whatever the amount of specialists that you need, it would still be inpatient rehab.
Yes,
Okay.
Of course.
That's interesting. So I was wondering, as Claudine said, you still motivating to have a feedback on the workload and the complexity of your patients. I'm guessing that use data. I'm wondering about the completeness of the data and how do you deal with it? Because it must not be missing at random. So I do believe that you must have trends in those missing data.
To be fair, missing data is very, very little. And the UKROC has already have regular meetings as well. So if one unit start to get missing data all the time, we need to feed back to them. So in Northwick Park, there is a UKROC data center. So there are 2-3 people making sure that all data is collected. And if the one center is missing data, we need to send them every 2 weeks. Imagine the whole UK, okay? Whole UK need to send the data to that center. And we need to make sure that they are sending every week, but every 2 weeks is also fine. When they start to miss it, we send them like what is going on, okay? And every patient is actually registered. So if their UKROC data is missing, we will be able to know, okay? So, okay, we have the admission data, but where is the discharge data? Where is like weekly data? So there will be people, I mean, in your case, when you build Canada Rock, there needs to be probably people very diligent, making sure that everybody is collecting the right data. You may ask, I mean, at the end of the day, it's integrity, isn't it? They need to put the correct data in a timely fashion.
So maybe that was another one of my question, because in our case, just with the FIM in Quebec, we know that sometimes it's not, maybe it's not scored the same way from one judge, one nurse to another. So I'm wondering if part of the program also cares for training for the professionals, and how do you deal with that part?
Yeah, that's brilliant. So basically, yes, then there needs to be training, but training is not that difficult. I'll assure you. So if you are the doctor in the unit, and if I'm the one doing the UKROC or dependency scale, I will be able to teach you in half an hour and maybe less than that. We will do 2, 3 together and you will get the idea. It's the same for nurses. Obviously, we usually rely on the nurse in charge, whoever is the most senior, but anybody could learn this very easily. I'll send you the NPDS and NPDS as well. So you will see actually how easy the questions are.
Thank you, Dr. Karahacioğlu. So
you can call me Berkay. Berkay is fine.
used to call you Berkay.
No need to suffer. No need to suffer, Mohammed.
Thank you. Thank you very much. So gentle. So do you have any other questions? So don't hesitate to raise your hand or to write your questions in chat. We'll wait.
I saw in the chat that some people are asking for more, for follow-up, and I guess some people will need to listen back to the recording to absorb all of this content. This is what I saw in the chat. I guess, it's a lot of information to absorb in a moment. So we are actually, maybe Mohamed, for those who put that question in the chat, maybe you can explain what is the next, what are the next steps?
I can send the records with the survey email. So and anyway, we did publish the record on the CRIR website. So no worries. I'm gonna follow up with you for the record. I see that Perrine Ferré have questions, so you can go ahead.
Yeah, you will have to stop me, I believe. I'm very curious. In England, probably you also have programs with care that takes place at home. For example, in Quebec, we have this program with early discharge post-stroke. For those who can go back home, we provide the care at home instead of in an inpatient unit. So I was just curious if somehow you did compare the cost efficiency for that kind of care.
You know what? It is very interesting, actually. We must have had done something, but I don't have the details. We have recently done for ITB trials, intrathecal baclofen, and basically we create a nurse team, basically going there and reviewing the patients there for refills, and it seems to be very, very much cost effective. But using this model, you can probably do the research in the same way. You may need to probably add a bit more time for the, obviously you are spending a lot of time on the road, so you need to put that in, and gas, etc. But very easily you can do that.
Yeah,
and actually your cost is going to be much less, isn't it? Because it's not bad. There won't be any overnight nurse. I mean, that's really reasonable. We can create something for this, but this scoring system may not be able to cover that.
Yeah, because I'm wondering probably it also this population, because this trait of the population probably is going to fall into the less dependent ones also. So you might have some sort of collinearity or anyways. And also I was curious to see you didn't have stroke patients among your population of interest.
This was for trauma study. Actually, we have looked at the stroke as well. So, and in stroke, it's still very much cost effective, similar to these numbers, actually. I can send you these two.
Thank you so much.
No worries.
Thank you, Berkay. We have a question in the chat, Ibrahima Diallo. How flexible are moving a patient from different levels of care? Example from level 1 to 2 or the inverse.
So basically, when the patient comes to level 2 unit, they are going to stay in level 2 unit. So unless they become like significantly more complex, we don't really send them to level 1. So it's going to be their main rehab center. The same thing goes for level 1 too. Level 1, not necessarily going to level 2. We have some specialist unit. For example, they are specialists in PDOC, or they are specialists in tracheostomies. So for those units, there might sometimes be an agreement, okay? They may say, okay, this patient has these complex needs, but as soon as we deal with it, for example, the tracheostomy has been weaned, we will send back to this smaller unit or level 2 unit. By the way, level 2 units are not necessarily the smaller ones. They may have much bigger facilities. They might have much bigger, in higher number beds. That means that when it comes to the therapist per person or the doctor per patient is not the highest amount. So in some cases, it could be done, but most of the time, wherever the patient comes, it's going to be their primary rehab center, and they will probably follow them up in that center, or even after the discharge.
Thank you very much, Berkay. So if you have any other questions,
I can ask questions.
For sure.
Claudine, may I ask, how do you provide the, first of all, what is your financial system now? So how the hospitals or rehab centers in that sense get the money from the government? You have something like NHS as well, isn't it?
Wow, this is a difficult question. So we have organized a meeting where you will be invited so that we have someone from CIUS who is in charge of all this payment system answer these questions, but maybe some who are, I know some people left at this point who could have answered the question, but I have to tell you, I don't know the details of how this is organized at this point, and I don't see anybody raising a hand, so but for sure we will look at the different categories of costs. But what is very different for what you describe is that once a person gets home, the level of home care provided that never fills all the needs. There's always a part, I would say. I say always, maybe, but I'd say in a large proportion, the family will still have to sustain and cover part of the cost. Don't have as much the coverage is not as large as what you described. So for sure, that part is very different. But in the hospital side, how these units and how much the hospital gets for a patient, so I cannot answer. Sorry.
Claudine, even they say that we give set amount of money anyway, so it's not going to be cost effective. That's not true. Whatever the remaining need, the patient needs, which was filled with those beloved people, they are lost to economy anyway.
Yes.
Isn't it? So if they are doing like 5 hours of care work, they could have do that in an economy, open economy. They could have created a higher GDP, etc. So you can still argue it has lost the economy and it's lost the bigger system. So you can still show the cost effectiveness, even though the calculation method is different.
Yes, this is why I think Philippe asked that question at the beginning, you know, how do you include that cost and what are the strategies? But I know some researchers in Quebec have developed such tools to capture the cost for families, so we could complement with these tools. So I see two hands raised now, so I'll stop here.
Yes, Dalia, you can go ahead.
So I guess what my thought is on this is that I'm not gonna solve any of it, and I totally hear Claudine's concerns with our system and trying to apply it to our system. What I really like about what you did is it takes a broad perspective of different costs. Okay, so it looks at costs from different perspectives, including from the caregiver. It's caregiving, but it could be applied to the caregiver, or it can be a resource that is doing the caregiving. So I think what I'm hearing is we need data, and then it has to be seen as different, not necessarily as this is the way we have the data now and this is what's being done, but we have the data, this is what's being done, and what are alternative ways of being able to do it to meet those needs, some of which may be more cost effective than others and more applicable in certain regions maybe, or there may be different ways to meet the different needs, which will have different care costs. That's how I kind of see that the data could be used. Because I think absolutely, I agree, it would be very hard to use it as is and demonstrate it works, it's cost effective, so keep giving us money or give us more money. I think it has to be interpreted correctly.
Yes, you're right. I mean, to be fair, my father is an oncologist. And when I explain this cost effectiveness, like I'm doing like cost effectiveness in rehabilitation, what does even that mean? Because in their case, okay, in most doctors, okay, if for example, think about an oncological treatment, okay, if it's effective, it's going to increase the life, and that life is going to be, let's say, from country to country it changes, but let's say every gained year worth £100,000, and if that treatment is going to increase that year, 1 year, 2 year, it is worth paying like 100K, 200K, whatever. So in their case, it's very easy to calculate this. Whereas in rehab, it is not. It is very, very complex because there is this carer cost as well. So we need to be very careful because when we say independence, when we do PIMFAM, what does PIMFAM show? PIMFAM shows independence, isn't it? But obviously that translates to more, less care in the following years. And less care means less cost. So calculation is actually very, very difficult and it is not intuitive either. So that's why it needs to be very well emphasized. As you said, it needs to be interpreted. So, and the commissioner needs to understand this as well. So commissioner needs to study this.
Thank you very much, Berkay. Philippe?
Yeah, I'm not an expert or a health economist, but from what I understand, well, first of all, healthcare system in Canada is different between each province. There are similarities, but it's a provincial responsibility. So each province has their own healthcare system. But medical doctors are paid on a public insurance basis, so by every act that they perform and other factors. But the rest of the hospital systems, the healthcare professionals, the budgets are given to the hospitals more or less on a historical basis. So not necessarily on the number of cases and the type of cases that they see. So it's not, we give you X for for stroke rehabilitation, for each stroke patient, we give you X amount of dollars. They provide, the hospital gets the budget, which is distributed among the programs, and there's a lot of negotiation on who gets what. But and they've been some people wanting to move to more of a patient-based last health minister. It hasn't been done. So it leads to inequality with regions getting more because the number of the population grows in some parts of the country, the province, and less so in others. Needs change with time, populations age, but the budgets remain. It's you're getting whatever you got last year plus 3% or something like that, and you do your best. So yeah, so it's harder to calculate. Maybe it makes probably some of those calculations harder because the unit cost will not be the same everywhere, but you could still figure out the time. There's still ways around that by figuring out how much time the length of stay and things like that.
Yeah, yeah. But I mean, this data, I mean, when you build it in Canada, it's going to show the system because Canada is a social system, as I understand.
Yeah.
They're not going to leave their citizens suffering, and they value the human life. They value the dignified living, isn't it? So if they are not able to feed themselves in the morning, there needs to be someone actually feeding them.
Of course.
We are on the same page.
Yeah.
So that means that we can show if you don't fund this project, if you don't fund this specialist rehabilitation, in the long run, you're going to lose money. If you think that whatever we don't give, the family is going to cover it, that's fine. They are still losing money to economy. So, and they are not professional either. If you think that the same amount of care is going to be given by a wife, that's not the same. The caring is a very professional thing. So, I mean, changing.
I totally I agree 1000% with you, but unfortunately, governments often don't think like that. They think they can save money everywhere, and they think about, they're concerned about cutting costs in every of their every of their pockets, without thinking of repercussion it can have elsewhere.
Yeah.
So they cut, for example, we have a home adaptation program, which makes people more independent and more able to remain independently in their homes. And they've cut it. So that means that more people will have to go to specialized care, which costs a lot more. But for them, they're saving money on a program, and it's very short-term view and very not only short-term, but very narrow-minded. We want to save here, so what can we cut this? And it doesn't matter. They don't think about what it's going to cost years from now in another program that they will have to pay. Yeah.
The good thing is, with this data, when you start to collect, they just need to only see the next 6 months, because most of the conditions are going to be offsetting the cost in the next 6 months.
Exactly.
Okay. So
I agree. But we need to convince people. So maybe Claudine, that's one point that we can talk about, because we're meeting.
Yeah, I think people have to leave for the afternoon, so I'll let Mohamed finish. But Berkay, this is to be continued, as we said, and maybe next time, with a person who can answer your questions more in depth will be helpful to continue this. Your understanding on how this is functioning here in Canada. So I'll let you, Mohamed.
Thank you, Claudine. So we are coming to the end of this wonderful conference. Thank you again, Berkay, for being with us today and your generous insights. And thank you to everyone who joined us for this session today. It was a pleasure to have you with us. And I will be sending you a survey shortly, so please take a moment to fill it out. Your feedback will help us better make your expectation for future access activity. So, and I will try to attach the record of this conference in the survey email. So that's it. If you have any other questions or comments, please feel free to reach out to me by email. And thank you again.
Thank you very much for having me.
Thank you.
Thank you very much.
Thank you.